Hi, everyone, and thanks for joining us tonight to talk about the Arthrosurface WristMotion. We have Dr. Randall Culp on the line to go over this webinar tonight. He's in Philadelphia at the Philadelphia Hand Center. And Dr. Culp, if you're ready to take over, we can start the presentation.
Thank you, Nicole, and thanks for those that you can take some time to listen to what I think is a very exciting new alternative to many of the wrist fusion techniques that we've been using for many, many years in the treatment of snack and slack wrists, which are probably the most common condition you're going to see in your practices of arthritis. I do have a consulting agreement with Arthrosurface, and I think you should take that into account when you listen to my data. Slack wrist is very common, and as a matter of fact, in this prehistoric human that was unearthed recently in 1997, the human was 7,000 years old and had bilateral slack wrists. So it's been around a long time, and it's going to continue to be around a long time. And I think that the better treatments that we can offer our patients, the better we're going to be overall. Just as a review, what we're talking about is a slack wrist. Stage 1 means that only the radial styloid and the scaphoid are involved in arthritis. Stage 2 is when the entire scaphoid fossa is involved in on the radial side. The capitate is free of arthritis. And then 3 would be that the radial scaphoid joint is involved in addition to the proximal capitate. What we're talking about tonight mainly is stage 3. I have not yet done the capitate cap Arthrosurface on stage 2. I've been sorely tempted because my patients do so much better with the cap than they do the regular proximal corpectomies, but I have not done that yet. Decision making, magnitude of complaints. It is known that there is such a thing as an asymptomatic slack wrist. If the patient has no complaints and has a horrible looking x-ray, best course of treatment would be to do nothing. Age of patient is important, but really more important than the actual age is the biologic age. I have patients in my practice that are 80 years old that are extremely active, that I'd be more likely to perform a procedure to keep them on the golf course than some of my avid indoorsmen that are 50 years of age. Again, level of physical activity, and then finally the radiographic stage that we've just described. I'd like to review, if we could, just take a few minutes to look at what we've done in the past and how it relates to what we're doing now. Denervation was very popular about 20 years ago. Dick Berger and others at the Mayo Clinic have looked at this. Most studies that I've looked at in my own practice will show you that you're about a 50-50 chance of showing improvement if the patient already has an arthritic wrist. If the patient has a painful wrist and it's not arthritic, I think there may be a role for wrist denervation for pain relief. But my patients don't do well if the arthritis is already present. There's also some indications that wrist denervation may be involved with loss of proprioception and may indeed make the situation worse. So I would say wrist denervation is up in the air at this time. I think we've all done this procedure. I call it the porcupine operation, the 4-quadrant fusion, popularized, again, probably 20 or 30 years ago. It was the go-to procedure if you had a stage 3 slack wrist because the capitate was involved. I think most studies recently have shown that proximal corpectomy and slack wrist procedures or 4-quadrant fusion are similar in terms of their outcome, but the complication rates of the 4-quadrant fusion is higher, and that's been my experience. I've had non-unions, I've had implants that have moved, and I've had patients that have developed radiolunate arthritis later on. So it's still certainly an actor for certain types of patients. But I think that it's becoming probably less popular looking at some of the more recent studies. Capsular interposition was popularized by Dick Eaton back in 1996 in New York, where when he would do a proximal corpectomy for stage 3 arthritis, he actually would cut off the proximal capitate. and take either a proximal or distally based capsule and take it beneath the capitate and suture to the volar soft tissues. And the thought process was that maybe this will stop some of the inevitable arthritic changes that develop at the radiocapitate joints over time, albeit not necessarily symptomatic. And I've actually used this thought process with the capitate cap that I'm going to describe, and I'll go over that with you. The Oates procedure has been popularized by John Brigley out of Pittsburgh in some recent studies, whereas if you have a stage 3 slack wrist, he would take a plug of cartilage bone from one of the bones that were being removed in the proximal carpectomy and replace it in the capitate. And I think that there is a role for that, and I think that he's shown that there are some decent results with that. The only issue I have with it is that it really doesn't help in terms of your carpal height. Like one of the beefs that proximal carpectomy has had over the years is that you don't really develop a normal carpal height. It takes a long time for the soft tissues to shrink, and this is why patients with PRCs often take a year to get to their maximum improvement. And I don't see any difference with the Oates. Glenn Gaston described this procedure called a capitolunate fusion, and that would seem to be the ideal procedure for this problem. The only issue I have with it is that it is a small area fusion, and some patients that don't fuse well to begin with, even for a 4-quadrant fusion, will be even less so for this because of the smaller joint surface. I've had some of the hardware move or migrate, even with a successful fusion with this procedure, and so I have not adopted this as my prime procedure for stage 3. What about distal radius hemiarthroplasty? I looked at this for several years. One of the problems I had was that if you look over here on the x-ray of the CAT scan on the left, it appeared to me that the surrounding carpal bones were eroding into the metal, even maybe because of the shape of the implant. And so my patients weren't doing well. They were having persistent symptoms, particularly in ulnar deviation. The x-ray on the right is what Scott Wolf is developing, called a mid-carpal arthroplasty. He is having some decent results with this. It's a different shape. It is not approved in the United States. He's been doing all of his work out of Great Britain, but has shown some reasonable results. And I think it's something we need to keep an eye on over time. And here's Scott's study just recently, Journal of Hand Surgery 2017, which he calls this a mid-carpal hemiarthroplasty, and it's showing some advantages and of maintaining mid-carpal motion, which is important in the dart throwers issue. So I keep an eye on this. If it ever gets approved in the U.S., it might be something to look at the right patient. I have also tried hemiarthroplasties on the carpal side, meaning I just took half of a total wrist replacement and put it on the carpal side, and they all failed miserably. They all subluxed ulnarward, as you can see in this x-ray on the right, and very quickly they eroded into the radius and all that. And so I abandoned that after a couple procedures. I just don't think they work. This is another new option. It is FDA approved. You don't have to try to talk your patients into this. This is already approved. It's a hemicapitate resurfacing implant. And basically what it does is it converts your capitate into a lunate. And one of the benefits of this is that the implant can be measured very precisely to the lunate fossa because there's different sizes of implants. And as I'll show you, the carpal height is improved. I think that's one of the explanations for how well they're doing to date. For those of you that have taken your boards recently, are going to the normal carpal height ratio, which is the ratio of the long metacarpal and the carpus itself is 0.52. For a proximal row carpectomy, immediately after surgery, the carpal height is about 0.37 and becomes worse over time because of loss of cartilage at the radiolunate fossa. So I think that's a major issue that we need to look into. I was intrigued recently by this study in 2015, which looked at the shape of the proximal capitate. I'm sure there are surgeons out there that have done a proximal carpectomy, and you looked at this pointy capitate and wondered how possibly this could last over time because of the lack of congruency between the capitate and the lunate fossa. The conclusion of this paper was that the shape of the proximal capitate did not affect outcomes. Yet, the same paper showed that poor congruency was associated with poor results for DASH scores of 5 years. So I guess I'm somewhat confused as of these sort of divergent conclusions in this paper. My patients that have odd shapes of the proximal capitate do not do as well with PRCs alone. So this is a hemicapitate implant. It's titanium alloy fixation screw with a cobalt chrome modular resurfacing cap, and it's connected via Morse taper. For those that have used it, once you tap that in, it's not coming out very easily. It does have porous ingrowth, and its beauty really is its simplicity. This is an easy procedure to perform. It's kind of difficult to mess it up. All of the animal models show terrific biocompatibility and bony ingrowth. Indications: slack wrist stage 3, as we've discussed. Stage 4, I have done a couple. The question one might ask is, what do you do with the lunate fossa if you have a stage 4? There's a variety of options that I will go over with you. If you really want to do a stage 4, snack wrist are the same indications as a stage 3 slack. Team box is a good indication for this. I will show you a few patients that I've converted from a fusion, unhappy patients. I have not done a lot of inflammatory arthritis. When we look at wrist replacements in inflammatory arthritis, other than a total wrist replacement, they have not fared as well. And I think that the jury's still out on whether this can be done on patients that have rheumatoid arthritis. Contraindications: inadequate bone quality. I'm going to show you an example of what can happen if you don't pay attention to that. Infection, of course, and then no wrist extensors is very important. If you don't have wrist extensors, you cannot do any wrist arthroplasty of any significance. This is a retrospective review. I started doing these in 2015. I am the only surgeon. All of the follow-ups are done by someone else. They're not done by me. We looked at grip strength, DASH scores, prior surgeries, complications, and it's still early. Rehab-wise, I've been immobilizing for 2 weeks. Some of my colleagues have been waiting for 4 weeks to give them a little bit more time for porous ingrowth. The screws in this procedure are so solid that I can't imagine moving them at 2 weeks is going to create any difficulties. And I think my motion is a little bit better. I give them a removable splint at 2 weeks and start active range of motion for 4 weeks. After that 6-week period, I remove the splint, start a strengthening protocol, weight bearing at 2 months, and impact activities at 3 months. I do not prevent patients from any sporting activity. A lot of my patients are 50 and 60-year-old golfers that want to play golf, but their wrist hurts and they can't play with a 4-quadrant fusion. They just can't get the motion that they need. And so that sort of be my ideal patient if you're going to start with one of these. Would be one of those. But I've had younger patients that have had much more aggressive athletic activities, and I've been letting them go. This is just a brief. These are methods to measure the lunate fossa. This is put on the capitate, and a pin goes through that. There's various sizes of these guides. The idea is to get this down through the capitate into the long metacarpal. And quite frankly, once that's done, the case is over. Because you put a little drill over the guide wire, get rid of some of the bone debris. You tap the hole, and you put this screw into that little laser line that you see right there. it's better to leave it a little bit proud than to go in too deep. Then you remove the screwdriver. You're going to then put some drills over that guide wire, which is going to go to the screw, the level of the screw. So you can't go any further. The screw will stop any further drilling over this guide wire. There's two of these. Again, they're sized depending on what you measured for your capitate and your lunate fossa. And you simply just drill this down to the screw. Again, get rid of some of the extra bony debris. Then, once you get the bony debris out, you're going to apply your implant and give it a tap. Don't be afraid to tap it hard. And what I do at this point is I try to pull it out as hard as I can. But if it's in there, that it's not coming out. I put it under the fluoro machine. It's fairly amazing how much motion you get. You'll see how much closer that is to the normal carpal height. And again, you look at this fluoro, you can get plenty of motion for your golfers to get some backspin on their irons. There's plenty of motion for pronation, supination as well for these sports. And a little dark on this fluoro, but it's pretty impressive how much you can move them when you're done. So I looked at 46 patients. The median age was 61 years, but as you can see, I did somebody that was a 33-year-old. 35 slack wrists, 5 snacks, 1 psoriatic, and 2 rheumatoids. 3 fusion conversions. 28 out of those 35 slack wrist patients had no prior surgery. All of the other patients had undergone at least 1 prior surgery. 6 of the patients only are greater than 2-year follow-up. Next year, that number is going to go up significantly. And so I'll be able to give you a lot more data with 2-year follow-up, which is what traditionally we like to see with any sort of arthroplasty. Preliminary results, average follow-up was 72 weeks, 1 to 78 weeks, so obviously early. Grip strength improved, motion improved quite a bit, quick dash score improved. Carpal height was right in the middle between a proximal carpectomy and a normal carpal height. So it's not normal, but it's certainly better than a PRC. I've had 2 complications to date and 1 revision to a fusion. The revision to a fusion was in a patient that was a workers' compensation patient from Philly who was doing quite well. I had no idea why he wanted to get a fusion, but we did that. I believe if you look at orthopedics in the past 50 years, traditionally metal on cartilage prostheses begin to wear away the cartilage side eventually. And so what I've been doing is I've been placing either a capsular in a position or some of the other techniques that I'm going to review beneath the capitate implant across the lunate fossa. And I'm going to try to buy some years with that soft tissue in a position, just as Dick Eaton tried to do with PRCs back in New York. Here's an example, 67-year-old right-hand dominant retired male, left wrist pain. He thinks he injured it playing football in college, progressively becoming worse. He tried the usual Voltaren gels and wraps, which didn't work. He had some decreased range of motion, had a markedly positive Watson test. And here's the kind of patient that you're going to see, as you see over here on the left, with a marked intrusion of the scaphoid on the radius and the scaphoid fossa. You have involvement of the proximal capitates, making it a stage 3, and sort of your classic capitate cap arthroplasty. 2.5-year follow-up, flexion of 45, extension of 45, 80% grip strength, no pain, plays golf, and he is ecstatic with it, and would encourage others to get the operation if you're a golfer at his level. Here's a complication that I had, and albeit it's a very weird case, but I probably should have picked this up when I saw this initial x-ray. 62-year-old caseworker had 1 year of wrist pain. And the first thing you'll notice is that if you look at the middle x-ray, that he's got a degenerative cyst here, and this is what I missed. But I was so entranced by this weird-looking x-ray because he looks like he already has a proximal corpectomy. But if you look at the lunate, which is protruding molarly, and if you look at his CAT scan protruding molarly, that is a very odd, strange x-ray. Anyway, I did the procedure. You can see, all of you can probably see, this is sort of creeping volarly already. I'm not real happy with the cartilage beneath that implant. A year and a half later, he came out the front. And what we did to resolve this is we put a artificial covering on the lunate. The other alternative would have been a Oates procedure, and he's back in the game. I don't know how long these artificial covers will last, whether it's allograft dermografts or menisci, but he's very happy with it because he's pain-free. The meniscus allograft is nothing new. The Mayo Clinic described this called the calamari procedure. Now, this was at the DRUJ. They used it for sigmoid notch resurfacing for patients that had ulnar head replacements and were eroding into the sigmoid notch. But it's the same concept. I have had physicians that have called me that have used this implant with bone anchors on the lunate fossa, and they said they were very happy with it. Very stable, pain-free. Same with the dermal allografts. There's a bundle of them out there that you can use. And again, as I mentioned, the Oates procedure can also be looked at. A couple other examples. This is a 50-year-old right-hand dominant chef in Philly. He's a well-known chef, and he has bilateral wrist pain. On his left side, you can see that there was this fusion procedure performed. We've got some problems in that the screws are broken. One of the screws looks loose, and he has motion on fluoroscopy, so he's a failed total wrist fusion on that side. This is what was done on the other side. It was attempted radioscapholunate fusion with pins. You can see where the bone graft was taken from the distal radius, and you can see that when the pins were removed, he is starting to have a separation between the scaphoid and the lunate. You can see he's got DRUJ issues here. As a matter of fact, the prior total wrist fusion, we also got some DRUJ issues as well. Because when you see some of the x-rays, you're going to notice that had to be dealt with. But so he has a non-union on both sides. One attempted total wrist fusion, one attempted radioscapholunate fusion, and both with DRUJ issues. And this is what we did. We did an Arthrosurface. On his left side, you can see the plate was removed. We left some of the screws in the long metacarpal. We did a Schecker on this procedure on this side for his DRUJ. We haven't used one of the other implants on the other side. And he's extremely happy. He's working full-time as a chef in Philly, and is very grateful to get rid of his fusions. Here's a patient that was peculiar because she had this wrist fusion for 17 years. And she came in and told me that she hated it, that she couldn't do her hair, she couldn't do all these things. And I said, look, it's kind of crazy to take down a fusion that's been there for 17 years. She goes, I want you to take it down. So I told her to think about it for almost 6 months. She came back and said she wanted it done. So we did this. She got 30 degrees of motion in each direction. I resurfaced the radius with a dermal allograft. You can see the bone anchors that were holding that in. One thing I wish I had done differently is I wish I'd contoured this part of the fusion on the radial side a little bit more, because I think she would have got better radial deviation. But she's very happy with it. Despite the fact that she had a total wrist fusion for 17 years, her wrist extensors worked fine. You retain that biologic memory somehow. We're not the only ones that are doing this in the States. They've been doing it for quite some time in Australia. They've been using a pyrocarbon implant as opposed to a metal implant. They looked at a paper with 29 patients, 35-month average follow-up, a variety of procedures. Did have 5 revisions to arthrodeses. Interestingly, 3 were Keenbox. But it wasn't clear from the look of the x-rays in the paper as to why they revised them to fusions, because they looked like they were in pretty good location. Example from their paper, 30-year-old male, snack wrist. Interestingly, had a previous excision of the proximal scaphoid. So I'd never experienced removing the proximal scaphoid. I've done Mallory's procedures where the distal half of the scaphoid's been removed, but I've never done a proximal scaphoid, which seems to me that would fail pretty miserably quickly, and that's what happened. So here at Princess Alexandra Hospital, this pyrocarbon was placed. This is a few years later. This is, again, 48-month follow-up, still in excellent alignment. Flexion of 15, extension of 45. No pain, is a jet skier. The same patient at 113-month follow-up, flexion of 10, extension of 65, excellent grip strength, minimal pain. You probably could talk yourself into saying that maybe there's a little erosion taking place here at the lunate fossa, but it's minimal for 113 months. I think that if we were able to interpose your favorite tissue in here, whether it's capsule, dermal allograft, meniscus, I think we can get some more years out of this. The Italians have also published papers using this pyrocarbon. In the patients, their pain relief was substantial and their function was improved. And their conclusion was that it's a good alternative to total and partial wrist arthrodesis, and I would agree. Now, when one looks at the radius of curvature, so if you look at in the coronal and sagittal planes, the lunate fossa have numbers that look like this. Proximal row carpectomy with the arthrosurface, we call it a PRC plus, are relatively close, especially in the sagittal plane, to the regular lunate fossa. The capitate is nowhere close. And I just can't imagine that this is not going to have better, quicker outcomes than the capitate alone. Again, we can measure this very accurately with the instruments that we have. So in discussion, we think that the radius of curvature mismatch on a PRC that will lead to degenerative changes eventually, albeit not necessarily symptomatic. I think there's a longer stage of improvement in a proximal carpectomy. I always tell my patients it's going to be upwards of a year before you get your maximal motion and grip strength back. Whereas that is not the case with these capitate caps. They get better much more quickly, get their grip strength back much more quickly. And I think it's because largely the carbal height. This hemiarthroplasty matches the lunate fossa very closely. It's reproducible. It can be used for mid-carbal arthritis. It is FDA approved. You don't have to worry about telling your patients that you're going to be doing something that's experimental. I think that we're going to find an excellent survivorship once we get more patients down the line, greater than 2 years follow-up. So I want to thank you for listening. I think I'm going to stop there, Avery, and open up to any questions that there might be.
So what kind of workout restrictions do you give your patients?
Well, again, I immobilize them for 2 weeks. I start moving them from week 2 to week 6 with a removable splint. I start a strengthening program at week 6. They can put weight on it at 2 months, and they have unrestricted activities by 3 months. So I've had patients to lift weights. I ask them to tape their wrist. I have patients that are on in pretty phenomenal athletic programs. So I'm not really giving them any restrictions at this point.
So specifically, I just wanted to clarify, it says, are they able to do push-ups?
Oh, yes. Yes, they are. Yes, they can do push-ups. They can do bench press.
Perfect. What's the survivorship of this implant?
Well, so far, for me anyway, I've only been putting them in since 2015, so the survivorship is 3 years. We obviously need a much longer follow-up. But I am encouraged by the Australians because they have 14-year follow-up survivorship. Different implant, pyrocarbon, but similar concept. So I'm encouraged by that.
Do you worry that there's a deep divot in the scaphoid fossa?
I don't. Like proximal carpectomies, the implant or the capitate does not shift out of the lunate fossa. I maybe seen one or two of those in my entire career. They usually go right back into the lunate fossa. It is important when you're doing your proximal carpectomy to preserve that radioscapocapitate ligament to prevent any ulnar subluxation or ulnar translocation. But I'm not worried about the implant going into that deep divot in the scaphoid.
Is this intended to also be used with a lunate fossa augment?
Oh, you mean is it originally designed for that? I think that a great theoretical use in the lunate would be to have the ability for us to put in a poly. But we have not gotten that through, and so we're using this as what I've described earlier as of course, capsular position has been described for years. That's nothing new. And I think that the dermal fascial augments is somewhat new and the meniscus is somewhat new, but the concept is the same. So if you're worried about doing something that is somewhat different, such as a dermal allograft or meniscus, I would simply do a capsular position, which has been described for years.
Okay, thank you. How proud do you leave the laser line on the screw to gain carpal height?
Yeah, a lot of it depends on the bone stock. When you're putting the screw in, some of these are so tight that the entire carpus is rotating, and you still have not reached the laser line. If that's the case, I leave it long, because you're just going to get better carpal height, and it's not going to get loose.
Do you have
I've had a couple, a millimeter at least, and I've had a real small woman that I did this on where the screw actually crossed the long CMC joint, and she had no problems with that whatsoever. We are in the process, at least I'm in the process of trying to talk to some engineers into giving us some different capitate caps length. Like if those of you that have done wrist replacements, you know that you have a +2 or a +4 that makes it longer. I would like to see that, to have that option, but it's not out there yet.
Do you ever see meniscus for wrapping the arthritic capitate head?
Have I ever seen the meniscus?
For wrapping the arthritic capitate head.
Without an implant, I've never done that. I have never done that without an implant.
He's following up with fixating it to the capitate.
Oh yes. I know what you mean. Yeah, the other alternative to what I described, which is putting it in the lunate fossa, is to use bone anchors to surround the capitate head. For example, you put in your capitate cap arthrosurface. You put the meniscus around it and use a bone anchor, for example, in the hamate. And put a bone anchor on the radial side, and then maybe put some sutures around the volar ligamentous structures volarly. And that seems to me to be absolutely reasonable. In fact, I've had some surgeons call me and said it's a lot easier for them to do these dermal allografts or a meniscus on the carpal side for fixation than it is on the radius side.
Okay, thank you. And what's the benefit of this procedure over a PRC with the capsular interposition?
Well, because what you do is you're comparing it to stage 3 PRCs that have had a capsular interposition, and the only data we have on that is from Dick Eaton way back when, because all of the studies on PRCs that have been published recently do not have stage 3, they're all stage 2s. So it's very difficult to compare. But if you look at the data that we have so far compared to what was done with the PRC stage 3s with the capsular interposition, our results are better.
Okay, thank you. So would this implant be used for carpal height if you were just going to end up wrapping the implant with meniscal or dermal graft?
Yes. Because theoretically, if you think about it, let's say you did the capitate cap, and then you put a meniscus around it and use bone anchors or on the lunate fossa, whichever side you choose, your carpal height is starting to approach normal. And I think that's going to be a tremendous impact on how fast people recover.
Thank you. What about without using the implant in that scenario?
So you'd have a stage 3 slack wrist, and you would simply suture the meniscus around the capitate, but not use the implant. I think that you would have some improvement in carpal height, but not nearly as much. And that truly would be pretty experimental. I'm not sure if there's any data on that.
What has been your experience with insurance reimbursement?
It's been excellent. And as a matter of fact, let me just give you, this is not sanctioned by Arthrosurface, by the way. I'm just going to give you some data from people that, surgeons that have called me for what they were reimbursed for. The proximal carpectomy is a code 25215. That's pretty standard. The capitate cap lunate implant arthroplasty is 25444. Those two automatically do get reimbursed. The issue is with the capsular interposition. 25310, which is really a soft tissue transfer code. Some have used that for tendon transfers, has been reimbursed. There's another set of soft tissue codes from 14000 to 14350 that have also been reimbursed by other surgeons. And some of this you're going to have to experiment. It depends what state you're in and what your insurance companies look at. In the beginning, I was using 25447 for the code for capsular interposition. The problem with that, I was getting paid, but I'm not sure how much longer I was going to get paid, because that's 2 arthroplasty codes in the same joint, which I know that insurance companies tend to frown upon. So you will absolutely get paid for 3 codes if you use the appropriate codes. The PRC and the lunate implant is a gimme.
Okay, well, thank you very much, Dr. Culp, for this webinar tonight.
My pleasure.
All right, thank you. Thank you, everyone, for logging on and watching. Take care.